So here's what HCV testing looked like at our laboratory. So prior to grant funding, we do perform a lot of testing for our correctional health services and clinics. We were previously doing the hepatitis C antibody, CMIA, on the Abbott Architect, and then we've recently transitioned to the Alinity. For correctional health services, our percent HCV screen positivity was 20%. So prior to grant funding, or prior to receiving this grant, the correctional health collected another specimen and sent to another laboratory for NAT confirmation. After grant funding, we were able to utilize this funding to validate and implement routine HCV NAT confirmation on all HIV antibody screen positive specimens. We performed the Aptima HCV Quant DX assay on the Hologic Panther, and we have able to secure continued state funding to allow us to continue this project both on our correctional health jail clinic specimens, as well as specimens that come from our clinic, and I will share that with you as well. So we received funding via the California Department of Health as part of the CDC Hepatitis Care Cascades grant. This was a collaboration with California Department of Public Health, University of California, San Francisco, Orange County Communicable Disease Control, our jails, Radiant Health Center, and Orange County Public Health Lab. The target population were people infected with HCV who inject drugs. The primary goals were to supply resources in the form of staff and to connect HCV positive individuals to care, testing, and then these linkage HCV portal initiatives to our patients. So the participants that were selected by CDPH for this study were 2 syringe exchange programs in 2 jails and 3 local health jurisdictions, Lake County, Plumas County, and then our correctional health facilities here in Orange County. We performed the verification and validation, and everything looked great. One of the issues that we saw with performing this assay was that in the instructions for use, serum must be centrifuged within 6 hours of collection. And this can be really difficult for our correctional health partners. For the clinics, it's pretty easy because they're across the parking lot, so the specimens get to us quickly. However, with the jails, if they collect, say, on a Friday, we may not get the specimen until Saturday or Sunday morning. And our staff may not be able to centrifuge these specimens until Monday. So what we really wanted to do was make this accessible to our correctional health partners, and allow for them for there to be some flexibility for that centrifugation step. So what we did was we had the jails collect 2 serum tubes per patient. They're labeled with the patient identifier, time collected, and either 1 or 2. We centrifuged tube 1 within 6 hours of collection, and then we kept the tubes in the refrigerator. And then number 2 was stored at 2 to 8 degrees Celsius and then centrifuged at 5 days. So that was, the 5-day was chosen because that was to accommodate the maximum number of days between specimen collection and receipt in the lab that we could identify. So on this graph here, you can see the results of our serum stability study. We did do a total of 23 samples, 8 negative and then 15 positive. And you can see that we had nice concordance at the log 10 value here shown on the left between all samples. We did have one that did not agree. It was actually not detected at the centrifuge within 6 hours. And then we did detect it was low level when it was centrifuged at 5 days. So we felt confident in the ability to be able to hold these specimens to 5 days and delay that 6-hour centrifugation step. Of course, specimens are centrifuged as soon as they do, as soon as possible once they come into the lab. So we don't wait 5 days to centrifuge. So talking a little bit about our algorithm here. And so what we chose was any screen reactive or equivocal, regardless of the value, or automatically reflex within our LIS to HCV RNA NAT. So here are the overall results of our study. So we had almost 9,000 specimens included in our study period. This is from October 2020 when we began through February of 2022, though this project is still ongoing. So of that, out of our total specimens, we had about 13% that were reactive. There were a subset of specimens that were not reflexed for reasons such as QNS or some other issue with the specimen, but we had about over 1,100 specimens reflexed. Of these, 635, or a little over 50%, had HCV RNA detected. And then we did have some QNS and invalid, but in low numbers. So now I'm going to break down on the next slide something that we found was interesting. So a majority of the specimens were from the jails, about half and half. But we saw a very distinct pattern between the correctional health and the non-jail results. So from October 2020 to February 2022, we had a total of 4,458 specimens from correctional health with a positivity or reactive rate of a little over 22%. Of these, 926 were reflexed to RNA, and 57% had HCV RNA detected. When we looked at our non-jail, so these are specimens that come from our county clinics, we saw a reactive rate of only 4%. Of the 189 that were reflexed to NAT, about 28% of these were HCV detected. So we see a big difference, which we would have expected because of the difference in the incarcerated population versus our clinic population. So I just wanted to touch a little bit on the patient outcome data. We weren't directly involved in this because this was really more of the patient navigator and the correctional health. But I just wanted to share that the number of patients that were linked to care. So was here we have an N of 265. And so 14% of those people had HCV RNA detected, and then they accepted navigation services. Again, this project is still ongoing. And so they are still working on linking these patients to care. I just wanted to share one example of this, our linkage to care working in our system, which we thought was pretty neat. So this patient, you can see the location, collection date, their screen result, and then a NAT result if they were reflexed and tested. So you can see that this patient tested negative 3 times at the jail. So in November and February of 2021, they tested negative. They were screened again in April of 2021, and they were screened positive and also had a HCV viral load reported. Now we see that they are now being seen in our county clinic. The screen was not performed because they were a known positive, but they continue to have their HCV RNA monitored post-treatment. We don't have any more data on this particular patient, but we thought it was a neat example of, seeing a patient, come out of the correctional health facility and then into care at our public health clinics. So in summary, the Aptima HCV RNA assay was implemented successfully. The serum stability study was done to accommodate our clients. We did have some delays in the beginning of getting our test results transmitted through the LIS to jails, and that kind of delayed our start date a little bit, but we were able to ultimately resolve this. There were some obvious additional delays by the COVID pandemic. And we chose to reflex equivocal specimens to HCV RNA since a low reactive result could signify someone who is in the early stages of seroconverting, and obtaining another sample may not be possible. Testing is now ongoing using state HCV grant funds, and the jails will continue to monitor how many patients are provided navigation services, how many receive treatment, and how many complete treatment. And I'll end with just some thank yous, especially to our Orange County Public Health Lab staff, Miriam Jawande, who did present on the poster yesterday, and Karen McLean, a microbiologist in our section. This was a great partnership between our OC Communicable Disease Control, Correctional Health Services, California Department of Public Health, and the project was led by Rachel McLean. And then here's some information on the funding source.